Right, good evening, everyone, and thank you so much for joining us for tonight's special Woo You event. Tonight, Dr. Zeta Syed is going to be discussing updates in keratoconus research, present and future. My name is Dr. Ariel Sorenzi, and I will be your host today. And a big thank you to Glaukos for providing an educational grant for this event. This will be worth 1 hour of CE credit, so please be sure to attend for a minimum of 50 minutes. For your COPE certificate, if you could fill out that survey link that will be in the chat shortly, and it'll also be there when the webinar ends. CE certificates will be emailed to you and sent to ARBO with your OE tracker numbers, but we'll also have a QR code at the end of the event that you can use your OE tracker app to get that credit instantly. Otherwise, you'll receive those certificates within about 4 weeks. Um, you can ask questions either at the bottom in Q&A or in the chat section. And then if you're on your phone, you can find the Q&A at the top or the chat feature under those three dots that say more. So I'm so excited to introduce our speaker tonight. Dr. Syed is a fellowship trained ophthalmologist who specializes in cornea, cataract, and refractive surgery. She serves as an associate professor of ophthalmology at Sidney Kimmel Medical College at Thomas Jefferson University and is the director of the Cornea Fellowship at Wills Eye Hospital. After graduating summa cum laude from Harvard College, Dr. Syed went on to graduate from Harvard Medical School. She completed her ophthalmology residency at Mass Eye and Ear Infirmary in Boston, Massachusetts. And after residency, she completed a fellowship in cornea and refractive surgery at Bascom Palmer Eye Institute in Miami, Florida. Just some of like the biggest names ever, just casual. It's really cool. Dr. Syed is the author of numerous book chapters and over 70 articles in the peer-reviewed literature. She has served on several committees for the American Academy of Ophthalmology, American Board of Ophthalmology, Cornea Society, American Society of Ocular Trauma, Eye Bank Association of America, and American Society of Cataract and Refractive Surgery. Among her many awards, Dr. Syed has been honored as a Heed Foundation Fellow, selected for the AAO Leadership Development Program, and has been featured as one to watch by Millennial Eye, as well as 40 under 40 by Ophthalmology Management. So here are her financial disclosures, all of which have been mitigated. So we're excited to hear from you, and I'll have you take it away from here.
All right, thank you, Dr. Sorenzi, and thank you everyone from Wu University for inviting me to speak tonight. I'm really excited to share with you guys some of the work I've been doing over the past few years. And at the end, I'm of course happy to take all your questions. So I'll be discussing updates in keratoconus research, present and future. And again, I'm Zeba Sayed. I'm on the cornea service at Wills here in Philadelphia. These are my disclosures. And so I'll first start off with kind of keratoconus diagnosis and management before we jump into the research aspect. As we know, keratoconus is a progressive condition. It involves central or paracentral posterior corneal protrusion along with anterior corneal steepening. Patients present with irregular astigmatism as well as stromal thinning. It's almost always bilateral, but often asymmetric, and it is very importantly non-inflammatory. And here you can see a patient with advanced keratoconus. When you look at a side profile, you see a pretty steep cone there with a classic sign of disease. It's pretty rare, although for many of us, it's very common in our practices, but it affects 1 to 2,000, depending on the definition and on the population. It tends to be sporadic, but 10% do have a family history. Onset is generally in adolescence, with progression through 20s and 30s, and usually stabilization by the late 30s. What are some associations? The big one is eye rubbing. I think my keratoconus patients in their nightmares hear me telling them not to rub their eyes. That's the most commonly used recommendation in my practice is not to rub your eyes. Atopy has been associated possibly because of the association with eye rubbing. Down syndrome as well. Again, it may be related to eye rubbing, that association is there. Various types of connective tissue disorders have been associated with keratoconus, as well as floppy eyelids and sleep apnea. The most important um, the most important aspect of managing keratoconus is diagnosing it as early as possible because the earlier we diagnose it, the earlier we can intervene with cross-linking to stabilize the patient's cornea at a level that is something that they can see well with. And so early signs of keratoconus are typically inferior steepening on topography. You can get an irregular retinoscopic reflex. You can see a Fleischer ring. I'll show you a picture of that in a second. You can see central or inferocentral corneal thinning, thinnest at the apex of the cone, and then you can see Vogt striae, which I'll also show you some pictures of. And here's an example of an inferior corneal thinning on topography, which is a pretty classic sign of keratoconus. Here, if you appreciate, I don't know if you can see my arrow, but I'm outlining a Fleischer ring. So you have this, due to the tear film at the base of the cone, you can get some tear film stasis, and you can get those deposits at the base of the cone, which we appreciate as a Fleischer ring on clinical exam. Here is a more advanced case of keratoconus, and with a thin slit beam, you can appreciate thinning at the apex of the cone as well as some scarring. And here are those classic Vogt striae, which are these kind of deep vertical stress lines in the deep stroma and Descemet membrane that you see in kind of moderate cases of keratoconus. And when you see them, they're pretty classic for this condition. Right? As keratoconus progresses, then you start seeing scarring. You can see these nodules that can be really uncomfortable in folks who wear contact lenses. And here is a patient where you can see this kind of this very wavy appearance of this apical corneal scar. And as well, you can appreciate a Fleischer ring in this patient. Now, patients can present with acute symptoms, specifically corneal hydrops, and this occurs when there's a sudden rupture in Descemet membrane in patients with keratoconus. This allows fluid to suddenly enter the corneal stroma, and it's very painful because the cornea, as we know, is the most highly innervated part of the human body. And so when you get this sudden rupture in Descemet membrane and this huge ingress of fluid, it stretches the nerves in the cornea and patients are in acute severe pain. On exam, you see severe corneal edema and an acute decrease in vision. And here's a classic appearance. You get this kind of central area, edema, bullae, and sometimes through it, you can appreciate the area of the Descemet tear. Over time, this will tend to scar over. So how do we treat it? It's often symptomatic management. We always tell our trainees this is not a patient that needs to come follow up every day until their hydrops resolve. You manage their symptoms and then you wait months for it to scar over. And so symptomatic management can involve muro drops, muro ointment. Sometimes they're very, very photophobic, in which case cycloplegia may help. Sometimes they're actually pretty inflamed, in which case I may prescribe a short course of topical steroids. They often resolve on their own over 3 to 6 months with scarring. And honestly, depending on where the scarring occurs, it may actually improve the vision if the scarring is outside the visual axis, because the scarring will cause flattening. And if you get flattening outside the visual axis, it may actually flatten your central case, and patients may experience improved vision or better contact lens tolerance. So when someone gets corneal hydrops, I don't tell them that, this has increased your chances of needing a corneal transplant. I actually tell them, let's see once it scars over how things look, and we can decide then what the next steps are. In early cases of keratoconus, folks often benefit from glasses, although if their keratoconus is progressing, they may experience frequent prescription changes. As their disease gets more advanced, they may benefit from contact lenses, often early soft lenses, if they're mild to moderate, but as they get more advanced disease, rigid gas permeable lenses, And then as they get more advanced, hybrid, or many of my patients are in scleral lenses for the most advanced cases. And now, if folks have a disease that is not amenable to contact lenses, or if patients are very intolerant of contact lenses, we start thinking about other types of surgeries. And so Intacs has kind of fallen out of favor in the US, and now what is gaining popularity is CTAC, or corneal tissue additive keratoplasty, which is the equivalent of Intacs but with actual cornea tissue um, that is inserted into pockets into the peripheral cornea or mid-peripheral cornea to cause central flattening and therefore improved vision as well as better contact lens tolerance. Um, but in the most severe cases, patients may benefit from full thickness or anterior lamellar keratoplasty in the form of DALK or PK. And so here are Intacs. We may see them even now, but very few centers in the US are doing a high volume of Intacs. They work great, but they have their associated risks, including extrusion, infection. And so CTAC is a little more safe long term just because the tissue is softer and can integrate better into the host cornea. Right? When the disease is too advanced, and this is how I convince my patients not to rub their eyes. If the disease progresses beyond what a contact lens can help and beyond what a comfortable contact lens fitting can provide, then we're looking at corneal transplantation. And in general, for our keratoconus patients, we are trying to perform a DALK, which is the ideal form of transplantation for keratoconus patients because DALK does not transplant the endothelium of the cornea. And so you basically replace all the anterior layers of the cornea and preserve the patient's own endothelium. And why is that important? Because the endothelium is the primary target of graft rejection. And so if a patient gets DULC, they theoretically have a very, very, very low chance of rejection because the primary target of rejection, which is endothelium, is the patient's own cells. And so DULC is the preferred surgical approach for keratoconus, but it would not work in a patient who has had hydrops and therefore has had kind of splitting or tearing of their decimate membrane because it makes the surgery much more challenging to perform. In an ideal world, I would love to perform DALK on every keratoconus patient that needs a transplant. But in the hands of most surgeons, DALK is much more challenging to perform than a penetrating keratoplasty because to successfully perform DALK, you need to actually separate the deep stroma from decimate membrane. And that is a very um, challenging plane to achieve. And often while trying to achieve that, we may kind of penetrate through decimate membrane. And in those cases, we convert to a penetrating keratoplasty. And so ultimately, most of these patients in the US end up getting PKs rather than DALKs. Although in Europe and other parts of the world, when we go to conferences, they seem to be doing primarily DALK. I think in the US, most of these end up being PKs, which are full thickness corneal transplants, which are higher risk of rejection than DALK. All right, and now we move on to crosslinking. So crosslinking, many of us kind of became familiar with it about 20 years ago when it was first developed in Europe. And then the Avedro crosslinking system was FDA approved in the US in 2016 to treat progressive keratoconus and post-refractive surgery ectasia. And so the goal here is to crosslink as early as possible. And we want to crosslink the moment progression is determined because I try to explain it to my patients as when we crosslink, we're freezing your corneas where they are now. And that way, if we wait a year and we crosslink you in a year, then we will freeze your cornea at where it is in a year, which could be a worse place than it is now. And that's usually a way of thinking that helps patients understand the importance of crosslinking as early as possible. And you basically want to cross-link at a point where the patient has satisfactory functional vision. You don't want to wait until the cornea is scarred and patients can't tolerate contacts or glasses. And so how does cross-linking work? It involves a combination of riboflavin and UV light to create free radicals in the cornea, and those free radicals cross-link stromal tissue. It strengthens the molecular bonds in the cornea, and the primary goal of cross-linking is to prevent progression. And I tell my patients our goals number 1 through 5 are to prevent progression. Some people get improved vision from cross-linking and may get some corneal flattening, but that is not the primary goal. My goal is to stabilize, and if we get corneal flattening and improved vision, I usually consider that a bonus. And that usually, I think, people will it'll set the expectations. Many folks do get flattening, but I don't like to um, kind of set that expectation just because if they don't, then they'll think that the treatment was in some way not successful. But I want them to understand that success, it means stopping of progression. And so the FDA approved protocol for cross-linking was the original Dresden protocol, in which a large epithelial defect is created, and then riboflavin drops are applied for 30 minutes, and then a UV light is applied for 30 minutes. So the whole procedure takes about an hour and 15 minutes, and then a bandage contact lens is placed and the patient is started on antibiotic drops as well as steroid drops. I'm going to present some data in a few minutes on cross-linking complications. Complications are very rare, but when they happen, they're devastating. And so, like my handful of patients that have had post cross-link um, corneal ulcers or corneal infections had poorer outcomes than when they started. And so we still want to make sure that we're cross-linking the right population and not just cross-linking everyone who comes in with keratoconus. Every procedure we weigh risks versus benefits, and there is a risk of infection and there is a risk of haze and scarring. And so I always counsel my patients on the importance of taking their antibiotic drops and kind of following up as scheduled with their clinician. And very recently, kind of hot off the press, we have this Epi-on protocol was FDA approved as of kind of 6 weeks ago or 2 months ago. And so slowly we will be transitioning from Epi-off, which is the original Dresden protocol, to an Epi-on protocol. And the Epi-off protocol will be phased out. And we will kind of that a protocol and that approach will no longer be serviced and we'll be all doing epi-on. And that'll probably happen in early 2026. And so those of you who have colleagues or are performing cross-linking, you'll notice that we will all be kind of switching over to an epi-on protocol starting in early 2026. Here's a picture of the epi-off protocol. One of my colleagues is performing that, and you see you shine this UV light. It kind of gets focused, centered on the cornea, and it's a 30-minute UV light treatment. The upcoming epi-on protocol will be a lot quicker, and it will not require as prolonged course of antibiotic and steroid drops because you don't make an epithelial defect. And so your risk of infection would be significantly lower, and your risk of haze will also be significantly lower in the epi-on protocol compared to epi-off. So the advantages of crosslink, the primary advantage is that it stabilizes keratoconus in over 95% of eyes for 10 years or longer. And that is a huge advancement in the field of keratoconus for a population that was once getting lots and lots of transplantations, and now we're doing so many fewer because of the popularity and adoption of cross-linking for our patients. And so I'm going to switch gears now to some of the research I've been working on. And so my first research question, so I'll preface this by saying that a lot of my research work is in kind of sociodemographic or socioeconomic aspects of health. And so one question that I proposed was that sure, we know genetic and environmental contributors to keratoconus. We know rubbing is linked. We know certain genetic predispositions are there. But what about social determinants? What social factors are associated with keratoconus treatment and keratoconus outcomes? And when I talk about social determinants, what exactly are we referring to? We are referring to demographic features such as age and sex, race and ethnicity, but we're also talking about other sociodemographic features such as what region of the country or world someone may live in, what type of insurance they may have, what their income is, what their education is. These are all social determinants of health that have shown to be relevant in other diseases, and so I was curious about how they are relevant for keratoconus. And so to answer this question, I tapped into the American Academy of Ophthalmology Iris Registry. And the Iris Registry is the world's largest comprehensive eye disease clinical registry. It includes almost a fourth of the US population. And we were lucky, our research team at Wills, we were lucky to have published our findings in the ophthalmology journal. And we published our findings on kind of trends and sociodemographic patterns in keratoconus management between 2015 and 2020. And we identified over 60,000 unique patients with a new diagnosis of keratoconus that we identified in the IRIS registry and included in our study. And the big advantage, obviously, of using the IRIS registry for research is you get a huge N. It's lovely to do, and I've done many studies looking at patients exclusively at wills, but that those studies are often not powered for the types of questions that I'm looking to answer. And so something like the IRIS registry, you really get the tens and 20, hundreds of thousands of patients that gives you enough numbers to identify even small associations. And so the first question that I sought to answer was, following the FDA approval of cross-linking in the US in 2016, how did the management of patients change? And so here is data from the IRIS registry showing that between 2015 and 2020, the light gray represents newly diagnosed keratoconus patients having no procedure. The dark gray represents newly diagnosed keratoconus patients having a transplant. And then the black represents newly diagnosed keratoconus patients having cross-linking. And so following the approval of cross-linking in 2016, you had a progressive rise in the percentage of patients who were newly diagnosed with keratoconus who underwent cross-linking, and a progressive decrease in the newly diagnosed keratoconus patients who had no procedure. And the percent of patients who had transplants seem to stay relatively stable, but fewer patients were getting no procedure and more patients were getting cross-linking. And so clearly there's been an uptick in cross-linking year after year as it becomes more widely available and more widely adopted. But my question that I proposed was, has this uptake in cross-linking, has this benefited all socioeconomic groups equally, and have all of our kind of different sociodemographic populations, have they all equally benefited from the advancements in keratoconus treatment in the form of cross-linking? And so I sought to look at sociodemographic associations of patients receiving cross-linking versus keratoplasty. So basically, what sociodemographic factors determine if someone gets cross-linked versus transplanted? And so this is a busy slide, so allow me to kind of orient us to what we're looking at. These are odds ratios, and the dotted line is an odds ratio of 1, which basically means no association. Numbers greater than 1 means higher odds ratio. Numbers less than 1 mean smaller odds ratio. And the black diamond represents patients having cross-linking versus no procedure. The light diamond represents patients having transplantation versus no procedure. And again, this dotted line is the reference value of 1, which means kind of no association either way. So we start with age. Compared to the youngest age group or the 0 to 20-year age group, older patients were in general more likely to be transplanted and less likely to be cross-linked. And basically what that means is, on the flip side, younger patients are more likely to be cross-linked and less likely to be transplanted. So why is this? This one was perhaps the easiest to explain. We know that younger patients have more rapid progression. Clinicians in general then are motivated to treat patients early when progression is first documented to preserve as much vision as possible. So this finding in the IRIS registry very much aligns with our practice and makes a lot of sense. Let's move on to sex. Compared to the female reference group, male patients were both more likely to be cross-linked and more likely to have had transplantation in the IRIS registry. Why is that? We know that there's increased prevalence of keratoconus among men compared to women, and that's been shown in various studies. And we know that there's an increased severity of keratoconus in men compared to women, and that's also been demonstrated in various studies. So when we move on now to race, that's where things get um, a little more interesting. Now, compared to the white reference population, we found that in the IRIS registry, Black or African American patients were less likely to be cross-linked because the dark diamond is less than 1, and they were more likely to have transplantation because that gray diamond is closer to between 2 and 2.5. So African Americans were less likely to be cross-linked and more likely to be transplanted. Asians, compared to white patients, were less likely to be cross-linked or transplanted. Similarly, when looking at ethnicity compared to not Hispanic or Latino populations, Hispanic or Latino patients were more likely to be transplanted as well as cross-linked. So how can we explain some of these findings? Well, one is genetic variables. Various genetic genes, various keratoconus genes have been identified, and these are listed here on the right. And so it's known that there's a higher incidence in populations such as South Asian, Black, and Hispanic descent. And so these genetic variables may explain some of these findings. And it's possible that folks in these genetic groups may have more severe cases of keratoconus at presentation that are perhaps not candidates for cross-linking and they end up needing transplantation. But we cannot ignore the possibility of social variables as well, including differences in insurance, differences in access to corneal specialists across racial and ethnic groups, language barriers. So these are all variables that we try to think about when we try to interpret these findings. The data in the Asian population has been inconsistent, with some studies showing both increased and decreased odds of keratoconus compared to white patients, depending on what population is being looked at, what part of the country we're looking at, what part of the world we're looking at. And so that finding I don't have a great explanation for, but I do think it's important to think about the findings that we identified in the Black and Hispanic populations. So when you move on to region, this is also very interesting. So compared to the South, which was our reference group, West patients who lived in the West were more likely to be cross-linked versus having no procedure, as well as patients who lived in the Midwest were more likely to be cross-linked. Compared to those who lived in the Northeast were less likely to be cross-linked and less likely to have transplantation. So, this one we scratched our heads over for a while. How can we explain these regional differences? Well, one possibility is sunlight exposure. Different regions of the country have different sunlight exposure, and it's possible that natural cross-linking can occur more or less depending on what part of the country you live in. That's a possibility, but it's a less likely mechanism. What's more likely is that there's differences in keratoconus diagnosis. There are probably differences in the availability of cornea surgeons. There's probably differences in the existence of cross-linking technology by region. In certain centers may have a higher density of practices that have cross-linking versus other parts of the country may have more um, kind of rural or underserved areas that may not have access to cross-linking. So that's something that I thought about, and I'm doing some follow-up research trying to identify the density of cornea surgeons in various parts of the country, and maybe that'll help me understand this association. Lastly, and what I find to be a huge struggle in managing these patients is the association between insurance and management. So in the IRIS registry, we found that compared to patients with commercial insurance, who are the reference population, those with Medicaid and Medicare were less likely to be cross-linked and more likely to be transplanted. And this very much aligns with what I see in my practice. And why is this? I mean, patients with Medicaid may be less successful in attaining eye appointments compared to those with private insurance. There are likely differences in the employment status and wealth between the insurance groups, but the biggest likelihood, most highest likely mechanism is the differences in coverage for the crosslink procedure and riboflavin medication based on type of insurance. We face this on a day-to-day basis for our kind of Medicaid keratoconus patients who we can't get cross-linking approved for. And it's very unfortunate that these patients will have transplantation covered by their insurance carrier, but they will not have cross-linking covered, which doesn't make sense to me, but it shows the importance of advocacy and the importance of working with your state societies on working to get insurance coverage for these patients. And it's a large population. I mean, I work in Philadelphia, in kind of downtown Philadelphia, and a lot of my patients have Medicaid and they have progressive keratoconus. And we really had no way to get them cross-linked unless they were involved in some kind of trials. When we were in the Epion trial, that was one mechanism that patients can get cross-linked with their insurance, but otherwise, these patients often are the only way they can get cross-linked is if they pay out of pocket. And these can be pretty cost prohibitive procedures. $5,000 is not going to be easy for many of these patients to pay out of pocket per eye. So this, I think, is a huge problem, and it probably is a reason why many of our Medicaid patients end up getting corneal transplants because they're not able to get cross-linked early enough. Education, we did not look at in the IRIS registry. There's no kind of quantitative way in the IRIS registry to assess education, but some of our colleagues did look at parental keratoconus literacy, and they found that high school education, limited English proficiency, lower income levels, and Medicaid or government insurance were correlated with more advanced disease, and they found statistical significance for the kind of limited education group or the high school education. So there's an association as well with education, which can be further evaluated. So to summarize our findings from our IRIS registry project, we found that patients undergoing cross-linking tended to be younger and white and with commercial insurance, whereas those who had transplantation tended to be older and black and had Medicaid. And patients living in the West and the Midwest were more likely to have cross-linking compared to the South, as while those in the Northeast were less likely to have cross-linking or transplantation compared to the South. And so we need to do further research to really understand these associations. And the IRIS registry has really allowed us to do these kind of big data work and really look at a massive population and help identify these kind of sociodemographic associations with keratoconus management. So that was one of the first research questions I had when it came to socioeconomics and keratoconus management. But it kind of led me to my next research question, which was, well, what about those who get cross-linking? Do they have equivalent outcomes? Does person A who underwent cross-linking have the same outcome as person B? And we recently published this paper that came out a couple of months ago looking at rates and risk factors for failure after cross-linking for keratoconus, again using the IRIS registry, just because cross-linking failure is so small, is so rare, and that number is so small if you look at any individual center. So the IRIS registry allows you to pool, tens of thousands of centers from across the country and look at all their data. And so in this study, we investigated rates and risk factors for cross-linking failure for patients with keratoconus using the IRIS registry. And the primary outcome was the failure rate at 3 years. And we defined failure as either having a repeat crosslink or a PK or a DULC after the initial crosslink procedure. And you may ask why not use keratometric data to define failure? And that's a limitation of the IRIS registry. The IRIS registry does not contain topographic or keratometric data. It actually is very much based on coding. So you can look at diagnosis codes, you can look at procedure codes. They don't have as much granular data, such as reliable keratometry, pentacam, things like that. And so we had to be creative on how we defined failure. And so ultimately, this population, after several exclusion criteria, we identified over 8,000 patients in over 11,000 eyes. And we found the failure rate at 3 and 5 years were 2 and 4.5% respectively. Very low failure rates, very much in line with what's published in the literature. And these numbers actually really help my day-to-day conversations with patients who are often curious about the success rate of cross-linking. And so what variables will affect failure? And so here are some survival curves that show kind of the overall population, and these survival curves kind of drop off as patients with cross-linking fail, and the months are shown along the x-axis. And so these are all univariable studies, and we do see that our Black population does have a more rapid drop off in survival, or basically absence of failure. So they failed more and they failed earlier on compared to the other population or the white population. So again, there's a sociodemographic association between race and cross-linking failure in this population. We also found that younger patients, so the kind of under 18 population, had a initial kind of failure, initial drop off at around 3 years. And so this ended up being significant. So younger populations were more likely to fail, and that is consistent with our clinical practice. We often see patients who we cross-link very early, like late teens or early 20s have a higher chance of cross-linking failure compared to older patients, likely because they have more aggressive disease. And uh, interestingly, we didn't have a great explanation, but we did see a little bit of difference between our patients who had unilateral versus bilateral disease. It was hard to understand this association, but they kind of split apart and then they kind of came back together again. But the main primary sociodemographic associations we found were by race and by age. And these findings are consistent with our initial iris study that showed that these two variables also affect how patients are treated. And not only that, now we can show that these two factors, sociodemographic factors, also affect success after cross-linking. So this leads us to our third question is what groups tend to have more complications after cross-linking? Cross-linking, now we've shown in our IRIS registry study that it has 95+% success rate. Are there groups that have more complications after treatment? And kind of large scale studies of cross-linking complications in the US are limited. And so for this study, we actually looked at our own population at Wills Eye Hospital. So we looked at patients who had epi-off cross-linking by 8 surgeons at Wills between January 2018 and September 2023. And we identified about 833 eyes who from 670 patients who had cross-linking. And we found overall about 4% had a persistent epithelial defect lasting over 2 weeks. About 3.4% had a postoperative infiltrate, which could be infectious or non-infectious. So many of these were non-infectious infiltrates that were inflammatory. And then a large amount had corneal haze, 60 over 2/3 had corneal haze. This was measured at 3 months. And so most of these cases of corneal haze will resolve on their own after about 6 months. But we looked at persistent epithelial defects at 2 weeks, postoperative infiltrates at any point, and corneal haze up to 3 months. And these were our percentages. What we found was that persistent epithelial defects, what was associated with this complication, interestingly, the use of general anesthesia for cross-linking was very largely associated with a persistent epithelial defect. The odds ratio of 8.5 and significantly associated, as well as preoperative corneal scarring was associated with a persistent epi defect. And why is that? I mean, it was we thought about it for a while, and it's probable that those who needed general anesthesia for their cross-linking probably are those who may have other, maybe those who may have kind of intellectual disability or Down syndrome, or those who we can't perform in the office. And so maybe those are patients who have other factors that are contributing to them rubbing more. Maybe they're more likely to rub and have their contact lens fall out. And so that was our likely reasoning for why general anesthesia was associated with persistent defects. Now, preoperative corneal scarring was also associated with persistent epithelial defects. And our possible explanation is when you have kind of irregular corneal surface, maybe that in some ways there's some inhibition of epithelialization, maybe because if you're steeper, you can kind of have an area at the apex of the cone that may be more challenging to epithelialize. But we had a few possible explanations for that. And we also found that corneal haze was associated with thicker baseline pachymetry and younger age. And these associations were much closer to one, meaning clinically may not be super significant, but they were statistically significant. And why could this be? Well, those with thicker baseline pachymetry have more keratocytes, and keratocytes are responsible for haze that develops. So possibly that's why those with thicker corneas had more haze. Those who are younger tend to have more haze, and that can be because younger patients tend to be more pro-inflammatory, and maybe that's why they had more haze. But these were our findings for that study. And here we show it uh, kind of more visually. We saw that general anesthesia use was associated with a pretty high odds ratio of having a persistent epithelial defect, as well as corneal scarring was associated with epithelial defects. And then haze and age were also significantly, sorry, pachymetry and age were also associated with haze, although not much, not as significantly, not as clinically, meaning not as high odds ratios. And so those are three of my kind of primary projects I've worked on over the past few years. The future of research in keratoconus, especially in my area of interest, is in CTAC. And so this is a new technology for keratoconus that, as I mentioned, involves the implantation of corneal tissue into the mid-peripheral cornea to reshape the topography in patients with keratoconus. And so, what kinds of projects could we perform in patients undergoing CTAC? Well, we could look at quality of life outcomes. We can perform kind of quality of life improvement surveys in patients after undergoing CTAC. We can look at the effect on contact lens fit and contact lens tolerance. We can look at keratometric data after CTAC, look at improvements in corneal steepness, and compare this across patients with mild, moderate, or severe disease. We can look at training strategies for CTAC. One of the big questions when it comes to CTAC is what is its relationship to cross-linking? You know, in patients with progressive keratoconus, they often need cross-linking. So how should we perform CTAC relative to when we perform cross-linking? And so there are ideas to do studies comparing staging the CTAC first and then the cross-linking versus the cross-linking first and then CTAC, or should both procedures be combined? And if we're going to stage them, what's the optimal timing between the procedures? These are all questions that we don't know the answer to and that are great research questions moving forward. What is the long-term stability of CTAC over 3 or more years? This is not known. What is the impact of CTAC on higher order aberrations? This is not known. But these are all questions I'd like to kind of tackle in the next few years as this technology, as we use this technology more and more in patients. And thank you for your attention. I think we have some time for questions.
Awesome. Well, thank you for sharing all of that great information and all of the latest and greatest research that you found. We do have some questions in the Q&A, so we'll hop right into those. One of the questions is if you feel like you've seen an increase in high drops recently with the increased use of sclerals.
I have not. I don't feel like I've seen an increase in high drops recently. Have you all seen an increase?
I see mostly specialty contact lenses in my practice, and I can't say that I have.
I will mention one more
But
thing about high drops that I didn't mention earlier. I went to a recent World Cornea Congress meeting, and there was a group of cornea surgeons from abroad who very much advocated for surgical management of high drops with in the form of like compression sutures. So basically, the idea being that in folks who have high drops and have a tear in their Descemet membrane, rather than kind of sitting and waiting for that to scar over, there are some surgeons who actually advocate for an immediate placement of a suture to bring those edges of Descemet membrane back together and theoretically help the cornea heal faster with less scarring. And so that's I just thought I'd mention that because I didn't mention it earlier. It's a very cool technique. I've not tried it yet, but some of my colleagues abroad were big fans of it. And so I may consider it next time I see a hydrops patient.
yeah, that would be interesting. And it'd be also kind of interesting to navigate, like, how do you charge for that? Would it be,
Yeah.
would it be covered by their insurance? It's cool. You'll have to update us next time that you're on Woo. Is there what is the lowest endothelial cell count recommended for DALK?
So there is no endothelial cell count recommendation for dogs. So we don't actually do speculars in these patients. It's a clinical, basically, if you are comfortable clinically with the appearance of Descemet membrane, then we go ahead and perform DALK. It's in general, these are not patients that have endothelial disease. I can imagine that there's a cohort of patients that have both Fuchs and keratoconus, and in those patients, perhaps there'd be an interest in looking at endothelial cell counts. But in pure keratoconus patients, we usually don't do speculars, and we don't have a minimum cell count for DALK.
Okay, great. There were quite a few questions on epi cross-linking, so I'll ask a few of them kind of all at the same time. One of them was if when we're comparing epi on to epi off, if the clinical trials show equal efficacy, and do you plan on treating a diagnosis for those at higher risk for progression?
So I will say that we don't have the epi on yet because it was just FDA approved, and so we're still working with glucose. So I don't have experience on comparing the two outcomes. Well, sorry, what was the second question?
So say that you see a patient that you pretty much know they're going to progress, they're very young age, and then have some of the other higher risk of progressions. Would you treat at diagnosis or would you still wait for progression?
Yeah, that's a great question. If I could do whatever I wanted in the world, I would treat a diagnosis. However, insurances often give us a hard time when we don't have documented progression, and that's been one of the challenges. In kids, I usually can convince insurances by presenting sequential glasses prescriptions and showing like a unreasonable change in their SIL or a change in their best corrected vision can usually be used to convince insurance companies. But there are also times where insurance companies say that's not enough. I want to see
Mhm.
documented pentacams, progressive pentacams, or topographic progression. So the answer is in a perfect world, yes. I would like to cross-link every pediatric keratoconus at my first visit, but insurances often provide a roadblock. And we had a
Mhm.
great talk at Will's a few weeks ago by Danielle Treef, who is a kind of pediatric cornea specialist, showing just how malleable the cornea is in these pediatric patients. And it's like even just from the position of their eyelids, their astigmatism is changing just from that degree of pressure. And so the impact of cross-linking is huge in that population. And so it's
Mm.
ever so important to cross-link those patients as quickly as we can convince the insurance companies to allow us to.
Great. And after Epi-on, does the patient still wear the bandage contact lens?
Yeah, this is interesting. So we met with our glucose reps a few nights ago to talk about the protocol. It sounds like in the trial, many patients still did have a contact lens on. I don't quite understand why. I think there was still
Mhm.
some level of discomfort, even though it was epi on. I think there was some level of an SPK or irritation on the ocular surface. So some patients did have a contact lens on for a shorter amount of time, not the full week, but for a few days. Um, since we haven't implemented it yet in our practice, I can't give exact numbers of how many days and what percent of patients will need it. But the short answer is yes, some patients do get a BCL after Epi-on.
Great. And can you talk a little bit about the protocol for Epi-on?
So I actually don't know the details of that yet, since again
Okay,
we haven't implemented it
started
yet.
it.
But I'm
Right.
happy to share in the next 2 months we should have it up and running, and I will circle back.
Awesome. Thank you. Another question was if you are aware of any studies that demonstrate that certain diets can help strengthen the cornea. Any other advice in terms of lifestyle changes we can provide aside from not rubbing their eyes?
Interesting. Well, we were all impressed with the studies a few years ago that had patients taking like high doses of oral riboflavin and like hanging out on the beach. Remember
Yeah.
when
Yeah.
people were trying to show whether there are alternative ways to crosslink, and they're like taking these mega doses of riboflavin and exposing their corneas to natural UV light. I mean, I think that's more of an interest, but I don't actually think that there's uh, a reasonable amount of riboflavin that people take on a day-to-day basis that would help. But I don't know of any other dietary associations.
Great. And then do you recommend genetic testing for patients with keratoconus for like testing family members?
Yeah, that is interesting. So we do have genetic testing available. I do let our patients know that it is available, and it's up to the families and the parents whether they want to test their other children. Where it becomes, I think, very relevant is in patients who are undergoing refractive evaluation. So patients who want LASIK or PRK and have um, a relative with keratoconus. And so someone says, I had an uncle with keratoconus. I want LASIK. What are my
Hmm.
chances of having keratoconus? And that's the population that I will often offer genetic testing for. But my other typical keratoconus patients who come in, I will let parents know that this is an option and it's up to them whether they want to do it.
Great. And then what are some of the earliest signs that you see that push you to move forward with cross-linking?
Yeah. So we will get pentacams on all of our baseline keratoconus patients, and then we'll simply perform serial pentacams at every subsequent visit. And usually I'm seeing, depending on the patient's age, that will dictate the frequency I'm seeing them. So in my really young patients, teens and early 20s, I'm seeing them every 4 to 6 months. And then in my kind of older patients, 6 to 9 or maybe 6 to 12 months. And Pentacam is usually my kind of go-to diagnostic. Any um, my rule of thumb in cross-linking patients is I want to see objective and subject, and I want to hear subjective. So basically, if I see Pentacam progression, but the patient has zero complaints and they're not noticing it, I do not cross-link. And likewise, if the patient is complaining of worsening vision, but their testing or the objective is stable, I will not cross-link. I want to see both
Hmm.
subjective and objective. And the reason for that is that if I am seeing progression on the pentacam, but the patient is not complaining, and then I convince them to get cross-linked and they get a complication, then suddenly this is a situation where they were not bothered in the first place, and they were recommended
Hmm.
to have a treatment that now has resulted in some complication. And on the flip
Hmm.
side, if the patient is um, having subjective complaints, but their pentacams are not showing progression, then I don't want to cross-link them because their subjective complaints are probably from something else. Maybe some dry eye, maybe some other pathology, but it's likely not the keratoconus. So for me, it's pentacam progression plus a subjective complaint.
Okay, great. Last question. As so for some of those patients that experience corneal haze post cross-linking, is this something that is likely going to improve over time, or does it stay pretty stable? And is there any like further treatment that can be done for those cases?
It almost always resolves on its own. And I've had variable lengths of time of resolution. I've had some patients where it resolves by 3 months, some patients that it resolves by 6 months. Most of them are resolved by a year. So it's a lot of reassurance. And I actually try to be positive about it and tell patients, like, look, if there's haze, that means the cross-linking worked because, otherwise you wouldn't get haze. And I have not had a cross-link patient who has had like debilitating haze long term. Most patients have had, gradual improvement or resolution of their haze to either completely go away or to be at a point that is tolerable.